STEMI, myocardial injury, and we have to do this again, guys, because yes, we have improved in identifying type 2 demand ischemia, which is a good way to avoid readmission penalties on patients that truly have an elevation of troponins due to a mismatch on oxygen and perfusion. So let's go through this again. I remember Heather talk about this, and it's very important because there are penalties associated to this, and most importantly, we're not really pinpointing the right diagnosis. So again, type 1 MI is STEMI and NSTEMI. And you come to this definition by identifying coronary artery disease and disruption of the plaque. How does this different from type 2 MI? Type 2 MI, as now we all know, it's a demand ischemia. There's a different process going on that is causing this troponin elevation. Now these two can present the same way with a patient that comes with chest pain, chest pressure, but at the end, in type 2 MI, demand ischemia, there is an associated problem. There's a bigger problem happening, that sepsis, there could be heart failure exacerbation, there can be hypoxia, severe hypoxia. So if you identify a different process going on, there might be this situation that you're thinking that type 2 MI. But there's this new code or this new diagnosis that we have to keep in mind, and is the concept of nonischemic myocardial injury. So now think about those patients that come with, I don't know, they fell and the troponin is elevated, and they're calling you to admit this patient to rule out ACS. And you do all the process of an echocardiogram, and there's no alterations on the echocardiogram, there's no wall problems, the troponins went up and then down, the patient never had chest pressure. So this is not demand ischemia, and this is not type 1 MI, but you don't have a reason other than the fall could have triggered this troponin leak. So that's the cases that you should think into non-ischemic myocardial injury, which could be acute, or it could be chronic in patients that have an underlying disease, like for example, chronic kidney disease, chronic heart failure that are presenting without an acute exacerbation. But when you check the troponins, they're always going to be elevated at 0.04, 0.004. And so for those patients, think about non-ischemic myocardial injury.
So like a contusion, right? Like, you know, from a trauma, or a stretch, right? Chronic stretch, like in, you know, the heart failure, which is just always there, you know.
But it is really important, guys, when you get this query, because we're going to start working more on this, that you identify this as a possible cause if you come to that conclusion, because saying non-ischemic myocardial injury adjusts the patient's morbidity or mortality risk, which just saying chest pain due to MSK or musculoskeletal reasons doesn't. So if there is a troponin elevation with rise and fall, and no other reason for this patient to have this, and no signs of ischemia, then consider this diagnosis. Okay?
Right, you can even see this, right, if you have a patient that arrested for a non-cardiac reason, like let's say they arrested because of their hyperkalemia from their, you know, kidney failure, or from, right, and they got CPR, right, so, and now they have a trauma, you know, if you don't have any other evidence of them having a, you know, I mean, that would be hard to sort that from type 2, or maybe the demand ischemia from the arrest itself, but, you know, these kind of things. The important thing is that we absolutely cannot call something a type 1 MI, either STEMI or non-STEMI, unless we are absolutely sure that that's what it is. Because once we do that, then it puts us into a bucket for readmission penalty if that patient gets readmitted in 30 days for any reason, right? Any reason. So they came here with their MI, they went home, all was good. They, somebody dropped a barbell on their foot, they came back, that's a readmission penalty. Right? Totally unrelated, but so it's very easy, unfortunately, to get a readmission penalty in these patients and so we absolutely cannot call it a type 1 MI unless we are absolutely sure.
But more than penalties also comes to quality measures. So yes, please keep that in mind. Also for type 2 MI, if you're thinking that this is demand ischemia is not non-end-STEMI type 2. End-STEMI type 2 creates a confusion in the coders. So end-STEMI type 2, I think you're referring to type 2 demand ischemia, but they don't know that. They have to send you a query to see if this is type 1 or type 2. So instead of saying end-STEMI type 2, try to use type 2 MI demand ischemia.
Type 2 demand ischemia. And that then always has to come with what? Due to
underlying reason. But
severe anemia, sepsis, whatever.
But I do want to say that we have come a long way on fixing this problem from like where we were 3 years ago, where everything was end-STEMI. Now we're using more of the demand ischemia. Now we have to do one more step to identify the myocardial injuries, because those are important now. All right, thank you guys.